start with it. Perfect. All right. Now, do closed captions actually work again in Zoom?
You can't see yours? They're at the bottom of the screen.
Oh, then I must have turned them off. All right, good. So they work. Very good. So theoretically, and hopefully on your screens, if you like closed captions, you can get them. And we have the instructions here. And if you need support with that, put it in the chat. And Ellie and Cora will get back to you to help you with closed captions. Next slide, please. As a reminder, this is a NIDA-funded initiative that provides the seminar series. And these are the people behind the scenes who are organizing the topics and other initiatives within our overall R24 project that also provides the seminar series. And I see Jonathan Picard is here in the room today. So shout out to you. Great to have you here. Next slide. As you also probably know at this point, is that our NIDA-funded project that seeks to bring together key communities to advance the science on recovery community centers. We are part of founding the Consortium on Addiction Recovery Sciences, a science which goes beyond recovery community centers to also encompass other recovery science. And we usually provide the slide for everybody with current updated information about current initiatives. So you'll get the slides after the seminar and they'll be posted on the website so you can peruse at your leisure. I want to highlight that on January 20th, there's a letter of intent due for ISTA for their pilot funding program. So if you want to do research on recovery housing, check that out. There's also the work groups they're mentioning here, and there was something else we're going to highlight. Becoming a course member. If you want to talk, that would be great if you reach out to Amy Miracle and Carmen Masson. If you're interested, I'm also happy to make introductions. The toolkit, the community-based participatory research toolkit, we've mentioned a couple of times, but it's a beautiful PDF with lots of resources for things to think about when you are engaging in your research project, be it as a scientist or as a community partner, things to think through. So lots of stuff here. And a special issue on emerging adults and recovery is also coming soon. All right, next slide. We also have a request here from Faces and Voices to give them feedback. We've emailed out about this, but also wanted to remind you all here about it, to kindly click on this link here that you have to provide feedback to Faces and Voices of Recovery as they are planning for the next year and the future. And John, did you want to add anything to that?
No, just if you have the time and energy, please submit the survey. All of your feedback helps us to grow and change and all that stuff. Yeah.
Perfect. And in the chat, Amy, I saw you responding too about course. Anything you wanted to add about course membership or anything else related to course or anything at all?
So I just dropped into the chat information about the iStar pilot studies, but you guys already had that up there. But again, if people have questions about it, feel free to reach out to me directly. And COARs, yeah, please feel free to contact me about COARs as well. We are very excited about the 2026 NCARS conference. So I don't know if people are familiar with that or have attended that before, but it is on for 2026. So stay tuned for that.
And online or in person if you just wanted to?
So it will be a virtual conference this year again.
Beautiful. All right. Thank you. If you can go to the next slide, Liv. This is our place. So we're plugging lots of things, including our own list of recovery community centers. We try to keep track of all the wonderful RCCs that exist around the country. So when people ask us, is there an RCC near me? We can tell them with at least some information of what we know. So if you know of an RCC, and you want us to make sure that they're included, please drop them in the chat and Cora will then add you to our list. And if you want to take a look at what the list looks like, I think Ellie is dropping a link into the chat right now so you can download the list of RCCs, which is somewhere around 225 right now. So always appreciate more feedback on who should be on this list. Next slide. All right, perfect. Now we are off to our RCC live feature. Stacy, if I can turn it over to you to tell us what happens when you walk through the door of SICA.
Sure, absolutely. So thank you all for having me. My name is Stacy Charpentier. I am the executive director for the Connecticut Community for Addiction Recovery. Next slide. I just want to share a little bit about what happens in a recovery community center. So a lot of times people wonder, what happens and what are people greeted with when they come in? And at CCAR, you are greeted with warmth, a smile, as well as a group of people who are really just interested in helping you figure out what your recovery pathway is meant to look like for you. Next slide, please. So I always share our vision and our mission because this is something that we consistently model in all of our programming. So we envision a world where the power, hope, and healing of recovery from alcohol and other addictions is thoroughly understood and embraced. Our mission is simple. We put a face on recovery. We provide recovery support services and promote recovery from alcohol and other addictions through advocacy, education, and service. And obviously, we strive to end discrimination surrounding addiction and recovery. We try to open new doors, remove barriers, and we always honor multiple pathways of recovery. We want to make sure that anybody, regardless of where they are in their journey or what pathway they decide to use, that they're welcome. Next slide, please. So this is really important to us because we have a lot of values within our center that we typically honor within all of the spaces that we provide recovery support services. So one, our focus is on recovery first. We want to make sure that we don't mission drift ever. And so our focus is always on that principle. We also believe that you are in recovery if you say you are. We're not there to judge anybody or to describe what somebody's definition of recovery should be. As I said, there are many pathways of recovery. We focus on the recovery potential, not the pathology. We always want to stay positive. We err on the side of the recovery always. And we err on the side of being generous. And so one of the things that's important about that too is sometimes generosity also means saying no. It means maybe having somebody go through the motions in their journey so that they learn a lesson or two, and so sometimes, a lot of times, as people who want to help, we sometimes overhelp. And so we want to remember that we want somebody to grow in their journey. This isn't taking any part of the process away from them. And so sometimes being generous means actually having somebody do a little bit of work to get to an endpoint or a goal that they are looking to achieve. Next slide, please. So we have 8 recovery community centers throughout Connecticut, and you can see the list of them as well. While they all have their own unique flavor because of the community that makes them up, we have a lot of similar programs, and you also will get the same feel that reflects our values at every single one of our centers. We do have a few staff, usually 2 or 3, and then the rest of the programs and the rest of the meetings and groups and things that we bring are brought in by either outside people or volunteers that come into the center. Next slide, please. So we believe that recovery community centers are safe spaces, and they're recovery-oriented sanctuaries where people find belonging, explore all those different pathways, they build relationships, they learn, they grow, they have the opportunity to give back, which so many people talk about being one of the best things about being in recovery is giving back. And also to connect to resources and to experience hope. A lot of times, even just hearing somebody tell their story or seeing somebody grow within their process inspires hope in other people that they can do that for themselves. Next slide, please. So I'm not going to go through all the different multiple pathways, but as you can see, we honor every single one of them, and even some that aren't actually official pathways, right? If somebody comes in and they decide that they want to journal or they want to paint or they want to, whatever it is, talk to trees, whatever it is that they want to do that is important to them, we want to explore it. We also believe that people use multiple pathways through the recovery journey. Somebody may start with AA or 12-step fellowship, and then they decide that they want to try something else. So it's almost like a tapestry of different supports and pathways that can help someone along their journey. And we have groups that will honor any different pathway that somebody wants to bring into the center. Next slide, please. So when you come into CCAR, we ask two really important questions. How can we help you with your recovery today? Every single receptionist at the desk who is a volunteer for CCAR will ask that question because we want to know, what is it that you're looking for today? Sometimes I need help with resumes. Sometimes I want to go to a meeting. Sometimes I don't even know what I'm looking for. And so another question might be, if somebody's sitting with a staff member or one of our volunteer recovery coaches, is, what does recovery look like to you? We want to make sure that all of our services are person-centered. And so these two questions really allow that person to take control of what their experience with CCAR is and also what their experience in recovery is. Next slide, please. So we want people to feel that they belong. We want them to feel included. We want them to experience new beginnings and second chances. We want the community to feel supportive of each other, provide that hope, healing, community, positivity, and most importantly, love. You know, a lot of times people are afraid to say those things in professional spaces, but we do. We love on each other. You know, there is no a shortage of hugs and people, you know, just wishing each other well, congratulating each other. And it's really motivating and inspiring, you know, to just see people just have that love for each other. Next slide, please. So a lot of the recovery support services that we have are, again, like I said, we do a lot of meetings, a lot of different groups. But we have all recovery meetings, which are basically, we pick a topic, anybody can join, and we just allow anybody to kind of talk about and contribute towards what they feel about that topic. We have meetings that are geared towards women, men, young people, Spanish, the LGBTQ++ community. Like I said, we do bring in different groups that kind of focus on different pathways so people get an understanding of what some of those pathways are. We do a lot of training. We want to make sure that people see themselves as a leader in the recovery community as volunteers. And so we want them to be trained so that they can talk about, you know, maybe their story and why their story is important and how their story can maybe impact somebody else. We provide people help with pardons. We provide people ways to, even as volunteers, to do their own group facilitation so that it's not just staff running these meetings. We also do a lot of fun stuff. Journaling, yoga, arts and crafts, gardening, whatever it is. If somebody has an idea that they think would be a great group or meeting, bring it on. We'll get to it. We also provide telephone recovery support, and I'll get to that, as well as recovery coaching. And we do have a special program now that is targeted towards young people and family services. So we do have 3 recovery community center coordinators that focus on that, as well as a manager. And they run meetings and groups that are just geared towards that population. Next slide, please. So as I said, telephone recovery support. So we've been providing that service for over 20 years. We do weekly check-ins. We provide encouragement and support. A lot of times people who are new in recovery, they may have burned some bridges, and this program allows us to reach out to them. All they do is sign up. We have links on our website. Somebody signs up, they get a call for 12 weeks. Every week, somebody from the center will call in and just, hey, how's it going? This is so-and-so from CCAR. How can I help you? Is there anything that you're struggling with? Anything that I can help you figure out in your journey? But it is really a way to build that connection, but also it's win-win because the person providing the calls feels, again, like that giving of service and giving back, as well as knowing that they're a help to somebody else in somebody else's journey. And so it's been a really powerful program. I know numerous centers across the world have taken that on themselves, and we're really proud of it because we just celebrated 20 years of providing that service. Next slide. So before I wrap up, I just want to share some numbers from our annual report from 2024. As you can see, through our 8 centers, we serve a lot of people, and we provide a lot of different meetings and a lot of different value to people who come in 43,000 telephone recovery support calls made, 50,000 hours of volunteer service. As I said, we couldn't run what we do without our volunteers. 56,000 visits to CCARs and over 23,000 individuals served. So I just think, when you think about 8 centers in a small state like Connecticut, this is truly impactful. And what's amazing is a lot of the impact that is made is from the volunteers in those centers, because they're the ones that are greeting the people when they come in and making them feel welcome, so they want to come back for more. And then I believe my last slide is just our contact information, our website. If anybody ever, wants to get in touch, I will put my email in the chat as well. If you have any questions or want to learn anything else about CCAR, please let me know. And I just thank you for giving me the opportunity to take a few minutes and share a bit about what we do.
Awesome, Stacy. And the 20 years is so impressive and so wonderful. And also, when you said love and yellow and caps, you definitely feel that. We were there and we felt it. It is very palpable and part of what you all do, and it's inspiring.
Thank you so much.
All right, Liv, if you can move us to or Cora, I think, if you can move us to the next slide. As you all know, we're going to do some polling questions to kind of get our thoughts going for the presentation to come. So as always, fill out the questions and then use the gray tab on the right to progress onward. And when you are done completing things, please click the then blue submit button, and we will keep going until we have about 80% of everybody having completed this. All right, Liv, Cora, who's monitoring this? It's Liv who's monitoring, right?
Yes. We're at 66%.
All right, we'll give it a little bit longer. And certainly the questions we're raising in the last couple of ones are things you will hear about in the presentations and hopefully we'll all grapple together in the discussion with. How are we doing?
82%.
82%. We're exceeding. Excellent. All right.
Oh, there we go.
Awesome. Perfect. All right. So if you want, you can all scroll on your own screens, by the way. And if you scroll down to the questions, do you think peer recovery support workers should play a role in addressing suicidality? And the majority of us said yes, because it will come up. Some of us also says, well, but they would need to have clinical backup. And then some of us also says, ideally, no, that should not be a topic of discussion. And I think we'll hear and see all of those things in the data to come. Is it likely that suicidality comes up? 100% of us agree. So we all think it's going to be an issue. Perfect. And then do you think I think it's the first time I've ever seen 100% on any of our polling questions, by the way. Okay, just noting that for myself. Do you think peer recovery support workers have adequate training to handle suicidality? And most of us thought no. So we shall talk about what some of the barriers are and some of the issues are. Beautiful. All right, if we can go to the next slide, we will turn things over to Kristen, who is new to recovery community centers in the sense that she just learned a whole lot from Stacy about how it all works. And the data she's presenting is not from people employed at RCCs, but in other settings, but there's clear relevance to the work at RCCs. But Kristen, I will let you contextualize it yourself. Thank you so much for being here. Turning it over to you.
Wonderful. Thanks so much, Bettina. Everyone, I'm really pleased to be with you today. My experiences are far more in the mental health space. And so as Bettina mentioned, the work that I'm talking about actually comes out of that, but I see a lot of parallels and relevance. I'm going to share my slides here for all of you, and we can get started. And I'm just going to move some things on my screen so I can still see all of you while I'm presenting. I assume you all can see my slides now. Is that right?
Yes.
Okay, great. All right.
At least I hope Eileen also was able to get the slides. Thank you for the tech support in the chat.
So the work that I'm talking about today was done as a team, as most research is. And I'd just like to acknowledge a variety of collaborators here, as well as the NIH, who supported the work that was run out of the University of Michigan. I'm going to start by talking about the scope of suicide in the United States, and then I'll move more specifically into thinking about the role that peers can play in suicide prevention. And when I use the term peer, I'm really referring to peers who might be recovery specialists, recovery support workers, or might be more in the mental health space. And I'm just going to use that term peer more generically to cover everybody. And then I'll talk more concretely about our research study and what we found. And I'll be interested to hear your thoughts on those findings in the discussion. So starting with the scope of the problem with regard to suicide, the data I have here are from 2023. These are CDC data, so they gather national data, which usually comes from coroner's reports in the National Death Index. And so in 2023, over 49,000 people died by suicide. To give you a sense, that's twice the number of people who died by homicides that year. So it's really, in terms of scope, it is a significant number of people in our country. Suicide was the 11th leading cause of death overall in 2023, but it was the second leading cause of death in young people, which is really quite striking. And the fourth leading cause of death in folks who are approaching middle age. So that 11th leading kind of obscures maybe what might be even more of a prominent concern in younger people. At this rate, there's one suicide death every 11 minutes, meaning by the time we're done with this talk, 5 people will have died by suicide. And when we focus only on suicide deaths, we also miss
this has never happened before.
The people who are thinking about suicide or attempting suicide, but might not actually die by suicide. And there's large proportions of those folks as well. This group is probably well familiar with the data I'm presenting here, but just to illustrate again the relevance. Substance misuse is associated with a higher risk of suicide in general, but also across the specific substances I have listed here: alcohol, tobacco, opioids, cannabis, and amphetamines. So that means people who misuse any of these substances are at higher risk of suicide. And these data come from over, I think it's 47 different studies across 12 countries. So this is not one study. This is really kind of a good global look at things. And then mental disorders are also associated with an increased risk for suicide. And those data come from 7 different countries between 2000 and 2018. So again, not pinpointing one study, but really getting a broader look at that risk. As you're familiar, peers are professionals with lived experience who draw on their lived experience with substance use or with mental health to talk to people and live in service of others. There is really limited research on the role that peers play in peer interventions for preventing suicide. There's not a lot out there. And there's absolutely no consensus in the literature on best practices for peer-related involvement in suicide protocols or peer-delivered interventions. And yet, as you all agreed clearly, it's safe to say that peers are working closely with people who have suicidal ideation. So this is really where we started thinking about this. The question we're asking is ultimately, so what's actually happening, right? We know that peers are encountering people who experience suicidal ideation, and peers themselves, given their histories, likely have experienced suicidal ideation themselves and may have a lived experience to share with regard to that. So the question again is what happens? More concretely, we wondered how comfortable are peers and non-peer staff with the idea of peers discussing thoughts of suicide with patients or again with persons that they're serving or otherwise serving in suicide prevention roles. Are peer and non-peer staff comfortable with the workflows that are set in motion when thoughts of suicide are disclosed to a peer? And do peers feel prepared to address suicidal ideation if it comes up? So these are kind of some general questions we had in mind when we approached the study. So what I'm going to be talking about next is one component of a much broader study. And the broader study was actually testing the effectiveness of a 12-week peer-delivered intervention for people who experienced and had been hospitalized for either suicidal ideation or a suicide attempt. And so that was the broader context of this study. But what I'm going to be talking about specifically today are some interviews that we did following the study. And what we did was we were interviewing people that are in different roles in mostly community mental health centers. So we were interviewing peers, we were interviewing administrators, and we were interviewing clinicians. We interviewed a total of 22 people. 9 of them were peers. It's important to note that half of those people were peers who had experience in one of these work settings like community mental health, for example, but half also had been the people who were delivering the peer intervention in our study. So they had dual experiences. In terms of clinicians, there were 5 clinicians, and then there were 8 leaders or administrators. The work settings were predominantly, like I said, community, mental, or behavioral health. People could have more than one work setting, so these percentages don't add up to 100. Again, the peers from the PREVAIL study, 4 of them were participated in this as interviewees. One of the folks had been in FQHC and one had been, 2 of the folks had been in FQHC and one had been in the Veterans Health Administration. So folks were interviewed and we recorded those interviews. They were transcribed and anonymized. And then we employed a deductive content analysis approach where we started with a framework and then we were looking for particular things in these interviews. And the particular things we were looking at came out of an implementation science framework. And this framework really seeks to understand the context in which interventions get implemented and trying to understand what are the factors that might contribute to an intervention being implemented or not. And from that broader framework, we selected 4 different dimensions we were interested in. The first, and the font on this is a little bit small, I apologize, on the right, is patient needs. And so we were in particular looking to see if participants talked at all about their patients' needs with regard to suicidal ideation or more generally. We were interested in culture with regard to how the culture of the organizations was with regard to peers in general or peers addressing suicidality. Tension for change is the concept of understanding if there were parts of people's experiences that suggested that there needs to be a change with regard to peers' involvement in suicide prevention. And then the programs piece is thinking about what programs did people's organizations have with regard to addressing suicide risk. And we selected these dimensions from that implementation framework simply because they were most relevant to our research question. And then methodologically, we underwent something called code weaving, where you really look to see how these codes fit together in different ways. So I'm going to show with some exemplar quotes for each of these dimensions. So with regard to programs, overall, what we saw is that participants described programs for addressing suicide risk, risk assessment or mitigation. So what I mean by that are things like screening about suicidality and knowing, quote, what to do if someone reports suicidality. But there was really an absence of programs that were directly about suicide. Okay, so there was a lot about screening and risk assessment and what to do, but not a lot about a program that was targeted specifically for people with suicidal ideation who are struggling with that. So we thought of this as really saying, well, this is suggesting that there's a need. If there's a need for these protocols, we know there's a patient need around suicidality. Interestingly enough, there was nothing at all in any interviews that suggested any kind of formal policy, practice, or training that would encourage peers to actually engage in these conversations with the people they serve. And I'm going to read a couple quotes here. So these quotes are from, one is from an administrator and one is from a clinician. So the first is the staff, they do the Columbia screening. And if they have a high or moderate risk level, we have a pathway we follow where they're seen a lot quicker. So after initial intake, if they're at high risk, they're seen in 1 to 3 days. If they're at moderate level, they're 3 to 5. A safety plan is also done for anyone who's at high or moderate risk. That's an administrator. Sorry, and then a peers quote. Generally, if they demonstrated any form of ideation, we contact someone. We weren't really there to specifically help people who are suicidal, other than to make sure at the moment they're safe and stayed safe until we determined where they should go. And then next, after hospital discharge, that would be the entry point. During that assessment, whether a person needs or requests outpatient therapy, case management, psychiatric or medication monitoring, there's also assertive community treatment programs that would be for high-risk individuals, high risk and in terms of relapse, suicide attempts again. And obviously, if a person was actively suicidal, we petition to go back to the hospital. So it's basically a level of care assessment, and then they're offered what they need. So again, nothing that's really directly targeting any kind of suicidal ideation, rather more general programming or risk assessment. With regard to patient needs, I will note that all of these quotes come from peers, which is interesting. So peers discussed unmet patient needs related to factors underlying suicidality, such as feeling understood, having a safe space, and an understanding of the connection between existing services in an agency and recovery. So there was a disconnect that peers saw. One quote, "I was served by the same organization, and I would say they certainly didn't meet my needs. It's hard to, I can't really speak for other people, but for my take on it, they talked a really good talk about being recovery focused and having hope for people's futures. And then in reality, it still felt like a system about maintenance and crisis intervention rather than rebuilding." Next quote, "Sometimes when patients come in, quite a few of their bridges have been burned, and I'm their only support." Literally. I'm their only support because some have felt like, oh, I don't want to see a social worker. I don't want to see a psychologist. I just want to work with you, the peer. And that's great. But again, I'm not a licensed provider, so the work is limited, right? Some patients are like, oh my God, you're great. You should honestly be a clinician, you know. Are you going to be a social worker or a psychologist? And I'm like, no, I'm going to stay where I'm at because I like what I do. So this peer's saying, I feel like I'm helpful, but they seem like they want more, but I'm not really sure what to do with that. So there's this gap. And then the last quote, "I do feel like people often express frustration that they would only get attention when they were in the middle of a crisis, an imminent risk to their own life, versus trying to really help them find a path away from it. And they knew there were classes and things like that, but they often struggled to see the connection between what was offered in the classes and how that would help them have a better life." So we see here the peers, but interestingly, no clinicians or administrators, are really identifying some unmet needs that patients have. And again, these are some example quotes, but really, these were really not noted by clinicians and administrators. So the peers are tapping into that more could be done to support people. In terms of culture, non-peer staff, so that's clinicians and administrators, almost universally described a culture in which peers were valued, and yet they described them as not being used to their fullest potential in their organizations. Non-peer staff also spoke positively about peers' ability to interact with suicidal patients, saying things like they're really good at being comforting, they're really kind, they're really gentle, they're very supportive. So they saw that peers had some capacity for interacting with this population. Clinicians in particular expressed concern about putting too much responsibility on peers if they were to interact more and deliver suicide interventions. And peers really seemed to receive a message, an implicit message, that they should avoid conversations about suicidality because that's not their lane, and that they should, quote, stay in their lane. And so the culture examples I have here are one quote from an administrator and then one from a peer. So the administrator really expresses how peers are valued but underutilized. I think there could be more of a structured approach. Again, they're focusing more on wellness groups, meditation groups, coping groups, or the random referrals that happen when case managers see they're needed. I'd rather have peers be used for situations such as they're an increased symptomatology, or they're able to engage with the individual when they're symptomatic or after a suicide attempt or suicide ideation, being able to empathize and coordinate with that person, and to kind of be a support system following that. And then not just for a couple of weeks, but also now like you're part of the caseload until that person then decides they're no longer in need of peer services, or they're comfortable just having case management. So you can see this administrator kind of acknowledging that he thinks peers could do more with regard to suicidal ideation, and he's sort of envisioning what that might look like, but that they don't currently. The peer had a different take on the culture of the organization, and here's an example. When they come in, I have a checklist. Like I said, if the Columbia screening's been completed, I read it so I'm aware of it. I don't ask the question because I don't want the patient to feel like I'm prying. It's our first visit, let's get to know each other. Whatever they tell me is what they tell me. On subsequent visits, I may ask various questions, but I stay away from, I think I probably have maybe only asked that question. They're talking about asking if the person's thinking of suicide. Maybe 20 times in a 2-year span. It's just not my scope. If they say it, then yes, we do what we have to do. But if they don't, I just keep moving. So this almost feels a little bit like don't ask. Just don't ask. It's not my lane, and I'm not going to ask what might be going on. If it comes up, I have to deal with it, I will. In terms of tension for change, kind of putting together some of these pieces, participants described a culture overall that was really fostered by suicide risk mitigation protocols, which some peers perceived to have a chilling effect on their ability to engage meaningfully in conversations about suicide, which seemed to result in a tension for change among some peers. Some peers believed they could be more helpful to patients experiencing suicidality by listening and sharing their own experiences, but other peers were uncertain of how they'd engage with patients experiencing suicidality because they said they lacked training. And so an example of tension for change here that reflects the themes I identified for you above, I think that this is one of the things I often felt discouraged from engaging in conversations around it. And I suspect that more people had it on their minds than it ever came up in conversation when I was there. So I think it was known that at least maybe 40% of the people I worked with had dealt with it at some point. So they're talking about suicidal ideation. And I think that since it was so discouraged for the first few years of my employment there, I shied away from. I never directly asked anyone because I knew that if I asked and they gave me any kind of affirmative answer, I would have to turn them over to someone else and I'd be kept out of it and wouldn't be able to build my relationship with them. So I think I didn't get to do as deep of work with people for that reason. And this is simply a visual of what I've already said, but it sort of shows some overlap. And this is what I meant by kind of the methodology of code weaving, is it's not that each of these concepts are completely independent. They really are kind of integrated, and that we really were identifying some tension for change as a result of the intersection of these other codes. So the intersection of a culture where it's really focused maybe more on risk mitigation and less on actually delivering a service that would target suicidal ideation and support people in grappling with that. A culture where peers are valued, but perhaps underutilized. A culture where peers get the message to stay in their own lane and not even talk about suicide or ask about it, despite the fact that they may have lived experience to share. The idea in terms of patient needs, that maybe patients' needs with regard to talking about their experiences with suicidal ideation, or attempts for that matter, aren't being met. And then the idea that there's programs, but the programs may be more general programs, not specific to dealing with suicide, and that a lot of the focus on suicide is around risk mitigation, rather than actually treating people who are struggling with this and working with them. So some conclusions and implications. I've already kind of said the first bullet point here. Peers' roles in this seem to be kind of constrained, but they really may have something to offer, and they're an untapped resource that could be really useful in supporting people. But peers do lack training in this area, and some were unsure about how they would talk to people and share their stories about overcoming suicidal ideation. There is also a lack of evidence on any kind of peer-led protocols. This particular study, had some limitations. For example, we didn't interview anybody in RCCs, and I'm only learning about RCCs this week in more detail. And I'll be interested in your thoughts about how you think these findings would or wouldn't apply in an RCC. The other piece I would say is we had a fairly small sample, which is pretty consistent with qualitative work, but we also wondered if some of the positive views of peers that we were getting from administrators might be a result of what we would call demand characteristics, where they knew we were doing a study about peer suicide, and perhaps they were saying things more favorably than they really thought. We can't really be sure about that. Again, so there's really just a lack of any kind of evidence on peer-led suicide-related protocols. And the study that we did first, that I didn't talk about, that was a randomized trial over the span of 5 years, where we found that peers could deliver this suicide prevention intervention adequately and safely. But we didn't find that intervention did any better than usual care when it came to measuring suicidal ideation or attempts. Now, importantly, it didn't perform any worse than usual care either. It just didn't perform any better. And so really additional research would need to be done if we were thinking about looking for a specific model that peers would use to support people who are experiencing suicidality. And then the peers that were part of our trial for the 5 years wrote their own narrative that's actually under review at an academic journal right now, that shared their experiences delivering peer support in the context of this intervention. And what they identified as being useful to them was adequate training, supervision, support, and clinical backup is what they saw as the critical ingredients that allowed them to feel comfortable interacting with people who are experiencing suicidality. Those are the critical factors they noted. And at the bottom line is more research and evaluation is really needed to identify what are promising practices and what are the optimal roles for peers in this space.
Fantastic, Kristen. This is great. And you've might not have seen, but there's many requests for your slides already because it's really resonating and helpful to folks. I will turn it over to Susan, and we'll have to switch the sharing of screens, I think, because we have Susan's slide. Susan has done a lot of research on the peer workforce, and she's going to start us out on our discussion by sharing some of her reactions to the information that Kristen just presented.
Hi, thank you, everyone. Can you hear me okay?
Absolutely.
Great. Sorry I joined a little late. I had some computer issues. Cora I have a few slides that I will share, and Cora will run those. I want to start out by saying that thank you very much, Kristen. This was really interesting study, and some of the themes are very consistent from what we've seen in the research on peers over the past dozen or more years that I've been looking at this. So it's interesting to see that this is consistent with prior work. Looking at the poll, I think this is an important issue. Yes, this does come up. Everyone said yes. Needs more training. That was a huge issue too, with 77%. And this is a key issue. So let me tell you a little bit about, and I'm just going to go through these quickly, and you'll have them in your slides because I want to get to some discussion questions. So some general themes and challenges that I've seen over the years, and these slides also include some references for those of you that want to look at this a little bit more interesting, different kinds of approaches. The first piece, everybody knows what you all do as peer support specialists. And the connection that you have. I can say that there's definitely growth in this employment across settings and recovery centers and in a more traditional training centers in schools, in justice situations, post-hospitalization transition programs, et cetera. So definitely the recognition of the role in employment growth, and I'm talking about employment in this sense, is growing. Unfortunately, and maybe not totally unfortunately, but training and the potential for certification varies by state. It's a mishmash of programs, which impacts, where you are located state-wise, and also if you want to be able to move to another state and take your credential and training with you if that applies. Other movements in this area, whether you agree or disagree with the notion of billing for services or how easy it is, there's low take up on this, and that relates to some of the economic issues. And these regulations vary also. The next slide, I talk about some consistent workforce challenges that I've seen in prior research. So I'm just going to go through these quickly. I think they'll be familiar to you. Few states even track the level of employment and may or may not have a roster. So who is a peer recovery support worker and who isn't, and how would you find one? Work is often part-time with low wages. Re-entry into the workforce is an important part of recovery. Stigma is still an issue across settings, sometimes less in some settings than others. Acceptance from the professional workforce is quite varied, and that's changed a little bit over time, but not a lot. There's less development of new and newly integrated roles and settings in advanced training, and a lack of career development opportunities. These are things that have been more or less consistent over the years. The next slide. These are some resources for you to look at if you're interested. There was a systematic review that I did with some colleagues at the University of Michigan. And we looked at what's the evidence for the contribution of peers. And this was a systematic review looking at 14 studies. So you can look at that if you want to. Mental Health America had a report. And then we did a small pilot study on the financial contributions. It was during COVID, so it was a little bit difficult to find data, but we did find that, financially, the peer contribution, this is basically, costs for salaries and benefits compared to the income that comes in related to services, was kind of all over the map, depending on how people finance this service. The next slide. Okay, I had some discussion questions that I think may not be on the current version, but I can just ask them. Let me go to my questions. So given that, how is your experience at the RCCs the same or different from what you heard in this study in terms of providing peer support for clients or participants who express suicidality? That's one question. And I'll put all three questions on the table, and then we can discuss and certainly raise other questions. The second one was, everybody said we need more training. What additional training might peer recovery support workers need, and who should provide it? Should it be from a clinical perspective? Should it be from a recovery center perspective? Should it be, and from whom? And from what perspective? And what additional resources might you need in any setting to provide these services? Is it referral services? Is it immediate backup? Is it being part of the clinical team, et cetera? Actually, looking at my notes, a few more things I wanted to raise before we jump in, and I'll be really quick. The other thing that I have seen over time, and sometimes doesn't get mentioned, is the need to sustain recovery, to sustain your own recovery if you're a peer support worker. And how do you do that? Is it through supervision, and by whom? Is it by your work hours and work flexibility? Is it by being aware of the difference between yourself and clients, and what kind of goes into that? But it's a very important aspect. And then organizational readiness for this kind of work in terms of the whole team, no matter what kind of organization you're in, the whole team being ready to provide this particular service or other services, and being the peer being a full member of the team and participating in those discussions. So just some other themes that I've seen and other things you might want to discuss. So I'm going to stop now, and let's start with the discussion. I don't know who's moderating the discussion. Is that?
So I'll moderate, but only in the
Okay.
sense of that I'll acknowledge people when they're raising their hand. Everybody feel free to just unmute yourself and jump in. It's an open discussion for us all. And I see here that Liv has also put your questions, Susan, into the chat if you want to
Okay.
reread them. They are there. So who has a thought, comment, gut reaction to what you have just heard? Perfect, Erica. Go right ahead.
Hi, Erica Karshner from Communities for Recovery in Austin, Texas. I think the tendency is for peer support specialists to hear that someone is experiencing suicidal ideation, and we kind of throw up our hands and say, oh, wait, I'm not qualified for that. We need to call somebody else in, right? I'm thankful that at our organization, we have recognized that. And so one of the trainings that we have provided for our staff is it's the Applied Suicide Skills Intervention Training, Intervention Skills Training, ASSIST. And it takes into account that balance of, like, we don't want to destroy the peer relationship with our person, right? By just picking up the phone and calling somebody on their behalf. We need to hold the space and allow this person to talk about their feelings around suicidality. And so I think that we're doing a pretty good job of that. But I would always say that more training is good, right? We want to always have more training. So I think that any training program that keeps that takes into account that peer relationship, which is so sacred to peer support, is going to be a good fit.
Perfect, Erica. I would say that resonates strongly with things that we discussed in dress rehearsals, and also like the idea that Kristen just shared about in clinical settings, we have screening tools. That's not what the peer relationship is about. So you don't know ahead of time that this is an underlying issue, but at the same time, it might come up. It's there, and you're dealing with it in a very different way because the structure is very different around it. Go ahead, Pete.
Hi, good morning, everyone. So we do the peer training for Hawaii, and one of the things we do in the peer training is we train on, suicide, and then also grief and loss. And we find that those are two things that we know that they will experience in working with other individuals that usually isn't talked about. And I think having training on one, addressing some of their own experience around grief, loss, suicidality, suicide. Some of them have experienced family members that had death by suicide. So that given a individual comes to them and starts talking about suicidality, their own experience may come up in that and then cloud their judgment or their reaction and so really it's important with individuals' lived experience to turn them from lived experience to lived expertise, and knowing themselves to then be able to help other people, and knowing their reaction, and knowing the resources available, and how to assist somebody in that moment, and know the difference between when they should be supportive and when something is more than supportive and they need to bring in other assistance and other help in that situation. So, and sometimes they don't know what to do, and they may either underreact or overreact in the situation, if they don't have training in that. And I think that training for peers is essential because they are going to be working with individuals that have suicidality, or they individuals that have grief and loss. I think that all goes together, and I don't think we have enough. And the other thing I'm going to throw in there that we don't do enough for peers is trauma informed. I don't think that there's enough trauma informed training for peers as well, and it has to be based on their lived experience, not really didactic skills. It's really helping them to address, hopefully they address their own trauma, and then to be able to help others and to be aware of that. And I find that many peers don't even identify their own trauma, and so when they're presented with trauma, they don't really understand what that means for how they're presenting at that moment. So anyways, so those are just my thoughts on, I know I threw all that together, but I think that it's all related in some context. So thank you.
Perfect. And there's already some response for you in the chat. I'll call you next, Susan. But Kristen, you had reactions.
Yes, I just wanted to share that as part of our Prevail intervention, which again, I didn't talk about the main intervention, but one of the modules, I mean, and I don't even want to call it a module because that's not how the intervention was delivered. We had topics that peers were trained in, and then they could speak to, they could pick whichever topic they wanted to address at any time with a participant in the study, but one of them was grief and loss. So just like a nod to that, in addition to this being kind of an intervention that was geared toward talking about lived experience with suicide, we included different topics, and one of them specifically was around loss.
Also, trauma-informed care, was that also part of it, Kristen?
We didn't. That was actually an oversight on our part. We did not have that in there. Our main topics were really around hope, belongingness, learning from the suicidal crisis, kind of more like just general skills for kind of relaxation. And then the actual, and then grief and loss. And so peers could kind of talk about whatever topic sort of naturally came up. And then they had a kind of a quasi structure they would use to guide a conversation.
Very cool, very cool. Penny.
Hi, Penny Warner, recovery support peer specialist, mental health peer specialist from Communities for Recovery in Austin, Texas. I have found that I began as a recovery support peer specialist, but I have always identified as a person with a great deal of suicidality. It's been a major theme in my life. And being brave enough to also go and take the mental health peer specialist, because there is still so much stigma around talking about mental health, I mean, be it ADHD or, suicidality, depression, there's a great deal of stigma. And so I felt pretty brave, and I went and I took the mental health peer specialist training, and I learned from other peer specialists and earned that certificate from other peer specialists with mental health issues themselves that have recovery from that. And so I learned how to talk about my suicidality without re-traumatizing someone. I didn't know how to do that. And I was so scared to use my words harm someone, But I also learned from them how to be trauma informed, more trauma informed, and the impact of grief. And it just goes so much to what everyone's saying here, and how Phil in the chat said that it should be trained by people who also have that experience. It was an incredible, and it goes towards the question, what additional trainings might peer recovery support workers? I get that RS and MHPS tend to be a little bit separate. They are here anyway in Texas, I noticed, but they are merging. They're coming more closely together, and I think that's a real win-win for all of us. Thank you.
So true. I love it. You probably saw all the love for you being courageous and going out there and using your lived expertise to help others. And when you said I didn't know how to talk about it, who would? I mean, nobody is ever trained on that, right? And how to model that and how to learn about that is incredibly challenging. And I'm glad that you're bringing that up and that you're grappling with us about that. Kristen, Susan, Stacy, did you guys have gut reactions?
I do. I was just typing in the chat to not take too much verbal space, but I was thinking as you were talking, Penny, it's so wonderful that even in your general mental health peer training, that you were encouraged to think about delivering a story about your lived experience with overcoming suicidal ideation or grappling with it. And I'm not sure that's the case even in mental health trainings across the country. So as Susan noted, the training for peers varies widely from state to state. And that's a common topic that's addressed necessarily in peer training. And so I think it's really nice to hear that you had that,
Yeah, absolutely. I will note, go ahead.
I didn't want to take up any space either, but I'm enjoying the discussion and would like to hear from others about, what specific training are needed or what your experiences are in the recovery centers.
And we are all about taking space. This is the time and place to take space. So everybody, please feel free. I will note that it is 1 o'clock. You probably saw some folks hopping off because they didn't have the hour. We will still be here for the next half hour. The recording will stop here for the website and everything said after this point onward. We will summarize in notes. So feel free to discuss. It'll all be anonymous so we can dive more deeply into things.